Hello, good evening. It's Dr. Radiales from the Georgia office. So I usually will start by sharing a few cases that were of interest in the previous few days and open the floor for discussion. So one interesting case was I had a talk with a 43-year-old lady today. She had had 7 miscarriages and had one IVF cycle where she had 2 eggs fertilized and then one make it to a day 3 and did a fresh transfer that failed. Her AMH was zero point 0.8. Okay, and the discussion that we had was after her 7 miscarriages and essentially her failed IVF, whether she should do priming and try to do more IVF or jump directly into donor eggs. There was the question also about whether to do genetic testing because on her last miscarriage, the genetic material, the embryo was actually sent for analysis and showed to have trisomy or one of the trisomies. Um, and so the question was, okay, should I try to do PGT testing? But then based on her most recent IVF cycle, where she only had 2 eggs and one fertilized and make it to day 3, then chances that she was going to be able to do a PGT testing on her own eggs, it was going to be very, very difficult. So a lot of times in this fertility journey, we find a crossroad. Her numbers were not that bad because zero point 0.8 is not that bad for a 43-year-old, but her fertility journey till that point was a little challenging. So my discussion with her was that it's a very personal decision and that the fastest way to a baby would be donor eggs, and that choice is always going to be there. But that if she chose to do priming and PRP and try a few different things and try with her own eggs again, that was also acceptable. After all, it is your journey. So, and with CNY, you can actually do both. You can have plan A and plan B at the same time, where you go through IVF and we get what we get, but then you buy 4 to 6 donor eggs that get all fertilized at the same time. So even if your own embryos don't do as well, you have the backup of the donor eggs that have been fertilized. That was a discussion that I had with her as well. She wasn't sure in which direction she wanted to go. So she was kind of go and think about it and get back to us. But it's a discussion that we have all the time. And when is the right time to say, let's go donor eggs versus trying with your own eggs. Okay. I see that I have a few people popping in. Hi to everybody. Um, so I have PCOS. I would like to be okay transferring to embryo. I'm 21. So at 21, we do not recommend transferring to embryos. Why? Because the likelihood of both attaching is higher. And this is not a spontaneous twin pregnancy, okay? This would be a forced twin pregnancy that carries its own challenges. They've done studies comparing natural spontaneous pregnancies versus IVF pregnancies, and it seems that the placenta for IVF pregnancies is slightly weaker, so they tend to have more preterm labor and associated issues like that. Um, But let's say even spontaneous stream pregnancies are high risk for preeclampsia, gestational diabetes, miscarriage. So what's the point of getting pregnant to lose the babies at 10 or 12 weeks? So increased risk of preterm labor. What's the use of getting pregnant and having two very premature babies that might end up being disabled from complications from prematurity? So those are things that everything in life is risk and benefit. So the risk outweighs the benefit in this scenario. Why do we transfer more than one after a certain age? Because the chances of both of them attaching goes down, but the chances of pregnancy goes up by increasing the number of embryos transferred. But even then, we have to be very careful because Murphy's law it's crazy, that one time that you put three in, that's the one time that they all attach. Okay. How long does the Mirena IUD needs to be removed before frozen embryo transfer? It really depends on how long the IUD has been in, because the Mirena and that type of IUD, that family of progesterone IUDs, makes the lining very thin. So if you've had a Mirena for 10 years, kind of back to back, then you really want to do a few cycles where you build up that lining and kind of strengthen the endometrium and the uterus to be able to support a pregnancy. So I would definitely try to cycle a few times before trying to do a frozen embryo transfer. I've had 3 failed fresh transfers and 3 failed FETs with my own eggs and donor eggs. What should I try next? When you have that scenario, and I have encountered a few patients in your shoes, then you have to look at the uterine health. So there is such a thing as uterine priming, trying to figure out what's happening in your uterus. Are we dealing with endometriosis? Are we dealing with adenomyosis? Are we dealing with subclinical endometritis, so some sort of infection? Are we dealing with, like progesterone imbalance, and ERA would be beneficial as well to figure out if we need more or less progesterone before your transfers. So that's where I would start. And then definitely do all the diagnostic testing that needs to be done, ERA, laparoscopy, endometrial biopsy, hysteroscopy, and then treat with triple antibiotics. And lately I've been treating both male and female because you're having sex with your partner, and that is a closed ecosystem. What means is that you treat this partner, but this one you're going to have sex. So then it goes kind of back and forth. So I like to a lot of times just treat both partners and get it over with. Okay. If you have good beta numbers, what are the chances that a pregnancy actually progresses and a live birth occurs? Very high, very, very high. Now, beta numbers, so ACG numbers, it's relative. Okay, you can have very high numbers or you can have lower numbers, but what we're seeking is a progressive growth of those numbers. Okay. Rule of thumb, you want to see at least like a 60% increase in 48 hours in the first few weeks. After 10 weeks of pregnancy, those numbers, those ratios don't really continue that way. But the first few weeks of pregnancy, that's what we expect. Okay. My first FET failed. Should I change protocols? You can definitely go back and see if there's anything that can be tweaked. You can look at the labs. You can look at how the estrogen progesterone levels were, maintained, the lining, and then, whether we can spice it up with a higher level of immune protocol as well. Okay. Are medicated transfer more successful than modified natural transfers? The default protocols are medicated medicated transfers. However, there is more and more evidence that's showing that a lot of women do better with modified natural transfers. It's a little more tedious, the natural transfers or the modified natural transfers to follow, but more and more, I'm kind of putting people, especially if they had a failed transfer, and when I go back and I look at how they behaved, then I do a modified natural because, like the word says, is more natural. And instead of having hormone replacement, it's really supplementation, because since it's an ovulatory cycle, then you're going to be making progesterone on your own. Okay. When removing fibroids, what does the treatment look like following the procedure? What type of removal is recommended? I have 4 being removed sometime in June. It really depends on where the fibroids are and how big they are and what else is found during surgery. I've had, kind of many ways of skinning the cat. I've had patients that have a retrieval, go through a myomectomy, have another retrieval. So while their uterus is healing, we're kind of piling up the embryos. In general, you need at least 3 to 6 months for that uterus to heal. Some doctors are a lot more conservative and encourage to wait a whole year. But for 4 fibroids, depending on where they are, 3 to 6 months should be okay. And depending on what else is found, then you might want to do suppressive therapy for endometriosis, adenomyosis, but it's case by case. Could vaccines affect your cycle? I've had 2 vaccines and my body's not the same. I spot every day and don't know what to do. Of course, anything that you put in your body that is foreign can cause a reaction. Our immune system, yes, is very linked to the endocrine system. And the immune system is very linked to our healing system. So, I would have to, I mean, you can reach me concerning you. I have a few things on the natural side of things, herbal medicine and some glandular therapy to help your body kind of go back in sync. Okay. Can I request a doctor to do my ERA on a transfer? No, an ERA is actually a mock transfer. So it's like you have to use the exact medication that you're going to use during your transfer. It is a monitored cycle, just like you would monitor for a real transfer cycle. And then you have a biopsy on the 5th day of progesterone, and more exactly 121 hours after progesterone has started. And then based on those results, your real transfer is modified as needed. I have a consultation with you. 43-year-old, should I have my doctor take fresh blood work? Absolutely. If you can get like basic endocrine panel, that's huge. Your thyroid, prolactin, your AMH, especially if you're 43, that's going to give me a lot of information. Diabetes marker, your hemoglobin A1C, those things would be extremely valuable. Ultrasound, if you can check on your tubes, your husband or your partner, if you have a male partner, a semen analysis, that would be huge, because then we can actually have a very, very productive talk and devise a plan for you. Okay. My embryo was PGTA tested normal. The grading changed post-thaw and went from good average to fair poor, but still normal for the embryologist. Should I be concerned? No. You have to understand what the grading system is, okay? The grading system is very subjective and is based on the characteristics of how the embryo looks through the microscope, okay? The embryologist will give it a grade like, you have a kindergartner and they do a picture, they draw a picture, and you give them A, B, C on a subjective manner. But in the same way, looking at your kindergartner, your 5-year-old kid, maybe drew a picture that the teacher give them a C, and maybe that's the next president of the United States. So, we have a lot of poor graded embryos that are the winner and are the miracle rainbow baby. Okay. Especially if you have a genetically tested normal embryo, then don't worry about it. Keep your vibes up and just at peace. Will you have to have new blood work if it's over a year? Yes, because our bodies do change. Even our hormones change from months to months. That's why, actually, they change from day to day. That's why we draw blood on you guys that are going through fertility treatment so many times in a row. Okay. Can I request a doctor to my egg retrieval and transfer? Not really. What happens is, the way CNY is structured is that there are certain doctors that are mostly assigned to a specific clinic. However, we all rotate, okay? So, for example, I am mostly in the Georgia office, but sometimes I go to Syracuse. So we do rotate a little bit, and then once we are there, then we get assigned to an area. So it's kind of whoever the doctor that's assigned to that area is. Now, if, let's say, I'm in Syracuse and I am assigned to the transfer rooms, and there's somebody that wants Dr. Corley, then we flip, right? We try to honor the patients, but it's with the doctors that are there, okay? So most of the times, Dr. Corley, Dr. Luthinger, and Dr. Kills are in Syracuse, and then there's Dr. Banerjee and myself, and the doctor from Canada. I just lost it there for a second. We kind of come and go. So in that, if, let's say, if somebody is there that you want, then we'll flip and honor your desires. Can I get PRP for the uterus after fiber removal? To his absolutely. I recommend all of my post-ops to do PRP. Like, for example, I saw 2 of my tubal reversal patients, and I do PRP on them on ultrasound guidance to make sure that those tubes are healing right. So absolutely, after myomectomy, it would be very, very smart for you to do PRP. Okay. You had a saline, so Madeline had a saline and then didn't feel quite right, and you had PMS. Yes, I mean, anytime you poke your female organs, things can happen. Risks are small in general, but yes, something might have been disturbed in there, and then your period is late. What type of fertility medication would you recommend to conceive after a tubal reversal? Depending on the patient, depending on how the tubes healed. So, for example, if you have somebody that have both tubes that have completely healed, then something like oral medication and time intercourse should be enough. Sometimes one of the 2 tubes don't heal very well. We can do a medicated cycle to make sure that you ovulate from the side that's open, and some artificial insemination. Okay. Can you deny preconception blood work if you have no fertility problems? Not really. You'd be surprised how many times we find things in that preconception blood work that people were not aware of. I see that a lot on women that have had their tubes tied. So they had 5 kids in their 20s, have their tubes tied, come back in the late 30s to have another baby. And we do the routine stuff. We do it on everybody. And then we find some interesting things every now and then. And trust me, you don't want to cut corners. You're spending a lot of time money, travel, you want to make sure that there's nothing else that needs to be addressed prior to your treatment. Okay. So, is there a general list of preferred medications for issues as high blood pressure, high cholesterol? Um, so, yes and no, especially for high blood pressure, there's some preferred medications. The high cholesterol medication is really not the greatest to be in pregnancy, but if you get on a low carb diet, your cholesterol will improve. It's almost guaranteed, unless you have familial type of cholesterol disorder. And that's why you should have a consultation with one of our physicians prior to starting your IVF, so we can go over your medication list and your medication issues. Okay. Again, I do not recommend cutting corners. I've had I had a tubal reversal patient, and I usually will recommend some at least very basic testing, which she did. I also recommend for everybody that's having any sort of fertility treatment to have a semen analysis, which they denied. She went through this surgery. She healed great. She had no issues. And a year after her tubal reversal, finally came back into the clinic, and semen analysis was terrible. I mean, he had such a low sperm count, low motility, low morphology. So she went through a surgery that was unnecessary because she was never going to get pregnant on her own. She needed IVF regardless. Okay. If you have a medical condition that's life-threatening, I had a consultation today with somebody with history of pulmonary embolism. One of our friends here is talking about, a seizure disorder. You want to make sure that it is co-managed with either the neurologist or the pulmonologist or the cardiologist, whichever specialty needs to be part of the team, and that you are fully cleared. Okay, so if you have an active clot in your lungs, or your epilepsy is not fully controlled, then you're not going to be able to do your IVF treatment. Okay. So the PRP flush. So what is PRP? PRP is platelet-rich plasma. Okay, it's your own blood. We spin it, separate the cells from the liquid form, and the platelets are holding growth factors and healing factors. That's why it's platelet-rich plasma. And then we use it in different parts of the body. It's been around for about 15 years. And it helps, it promotes healing, and promotes collagen that is not scar forming. So that is what it is. So when you flush your tubes after a tubal reversal, then you're aiming at allowing those tubes to heal open and hopefully regain full functionality. Okay. Um, So yeah, so I am a fervent believer in PRP. I've used it. I've had like 10 years of experience in GYN with it. I have never seen anybody do poorly with it. Essentially, in my experience, and I have injected PRP on people in every possible place that you can guys think of. Okay, then I see either you don't see anything happening, or you see some improvement or a lot of improvement. Most cases, you see some improvement. Sometimes you don't get to see it immediately. That's where, like, one treatment, you can't see much, but then suddenly you do two or three, and then you go, oh, yeah, it's been accumulating inside the body. So I've never seen anyone with PRP actually get worse. In my career, 10 years, I've had one person react to the anticoagulant, and that was fairly fixed because we just changed the coagulant in the formula. Okay. It is your own blood, so there will not be an adverse reaction or a rejection, immunologic reaction, because it's your own stuff. Okay. We're just harvesting your own healing proteins and concentrating them and putting them where you need them. I have had, I personally haven't had a lot of experience with stem cell therapy. However, I've had mixed reports on that, because especially placental stem cell therapy, where it is a foreign cell. And I've had patients that have traveled outside of the United States, have the therapy, and it does mess up the first few months, their cycles, and their numbers can get really, really crazy. Okay. All right, all right. Yes, we do almost all of the PRP services in the Georgia office. The only one that we're not doing at the moment is the intra-ovarian PRP, because that does require anesthesia, and we don't have a OR in the Georgia office. But I do face PRP, joint PRP, back PRP, testicular PRP, vagina PRP, for sexual dysfunction PRP. So I have injected people. I inject my own mom in her knees. That's all I'm gonna say. So I've injected PRP in every possible place in the human body. Um, so eToro, those labs seem to be normal. Yep, those labs seem to be normal. Um, the Georgia office, it's in the waiting list to do IVF. We are at the moment behind Sarasota. But anything is possible, right? So, okay. All right, all right. Well, thank you all for joining tonight. As usual, I want to invite any of you that want to celebrate life and celebrate your victory. We're having an event in the Georgia office. It's called the V Celebration, because there's a victory waiting inside every one of you. So we are celebrating every miracle that we have. And it'll be in October. You can look it up in Eventbrite, or you can message me through Messenger at Mirabel Verdiales MD. Okay, so may you all be very, very blessed. I will see the English crowd in 2 weeks, and then the Spanish crowd next week. All right, have a blessed rest of your week. Bye bye.